rebooted my screen, and there we go.
Beautiful. Okay. Hey, everybody. Welcome to yet another Taylor Tuesday. There you go, Ira. I'm glad you got back on. And Dr. Chopra will get here shortly. We're really lucky. Ira will introduce our speaker, but we have one of the key opinion leaders in vascular medicine from the country on today with us, which is really exciting. So let's go to the first slide, Ira. Just a little warm up as usual for all of us. We're glad you could join us today. It looks like we're going to have a good crowd. Remember to use the Taylor Medical website and make sure you take a look. We record these webinars and save all these tremendous presentations, so you can go back and watch them after the fact and gather even more information. But make sure you can go to www.taylormedical.com, and you can click, as you can see in the arrows in the picture here up in the upper right-hand corner, for the webinar page. So another really important feature in the next slide, Ira, is remember that for those of you who have not taken advantage of our personalized medical supply cost analysis, please do so. So take the time, put together the products you're currently ordering with an Excel spreadsheet if at all possible. The name of the vendor, the item that you're looking for, the SKUs if you have them, units of measures, for example, if you're getting a 30 cc bottle, say, of lidocaine, and what you're paying for that. And then if you can email that spreadsheet to the admin, not the admin, but admin at taylormedical.com, Carla and her team will take a look and give you a cost analysis for saving money in your practice. I have not yet heard anybody say they've not saved money by using this platform. So take advantage of this. It's a free service. All of you that are already members of Taylor know that there's no fee to belong to Taylor, only pure upside and pure benefits. So please make sure you participate. Ira, I'm going to pass it over to you to introduce our very distinguished speaker.
Thanks, Mike. I really appreciate it. You know, it's kind of interesting. It's pretty cool. I've actually heard about Dr. Chopra for quite some time. Haven't had the pleasure of meeting him, despite spending a lot of time in Chicago. But I really am honored, and I want to thank Biomedix and John Romans for bringing him over to join us. And you know, we've been doing this now. We started doing this when COVID started. And we originally started out as a weekly program, and we've kind of toned it down, and we call it Taylor Tuesday, but every first and third Tuesday of every month, we have a different program. I think those of you are aware that this is a PAD Awareness Month. So I'm really glad that we have really a thought leader in this space coming to us. Just a quick synopsis or a quick update on Dr. Chopra. He's an interventional radiologist with over 30 years of experience in interventional radiology and endovascular therapy, and he's the president and CEO of MIMIT Health, one of the fastest growing physician groups in Illinois. He was awarded the Distinguished Physician Award and the U.S. Congressional Medal for Excellence only because I turned it down. I just want everybody to know that. He's renowned for his kind, authentic, patient-centered care. Which I think is critical in today's environment. And he has his care paradigm integrates the healing and nourishment of the spirit, soul, mind, and body. I wish I would have met him about 25 years ago. Anyway, it really is. I can go on and tell you all about his educational degree, but I get the impression that Romi, as he is fondly called, probably doesn't like hearing a lot about himself. I think he just wants to take care of his patients and do the right thing. So I'm going to turn it over to Romi, and Mike and I will be back to answer questions after he finishes talking to everybody. So Romi, I'm going to turn it over to you, and I'm going to disappear for a few minutes.
Thank you. Art. Thank you for that very, very kind introduction. We're based in Chicagoland, and we treat a lot of PAD. I'm passionate about taking care of people, solving their problems. And I tell people we're in the business of taking care of people, no matter what that is, but this is our core strength. We call it enlightened healthcare in the sense it's just about the whole human being at the center of everything else versus just doing a procedure or just treating one aspect of this. Feel free to check out our website, MIMIthealth.com. So thanks again. You know, the topics was named the Amazonification of healthcare, transforming to a patient-obsessed practice. I talk a lot about this, but the real topic, the essence for today is How can you, the podiatrist, and somebody like myself, an endovascular specialist, collaborate and provide excellent patient-centered care? And the paradigm today is better, faster, cheaper. Anybody who's been involved in any kind of project management anywhere, these are the triple constraints of life. You want something better, you won't get it if you want something high quality, you won't get it very cheap and you won't get it very fast. You want something very fast, you may not get an excellent quality and it won't be cheap, etc. So life within these three constraints, as you start doing them, that's what the Amazons of the world do. We'll talk about that a little bit, but I first want to tell you how PAD, what you do, what I do, how does that come into play? What's common, I've spoken to thousands of podiatrists, a lot of them are friends, we collaborate with many of them. I do want to thank Biomedix for making the introduction and having me speak here. And as full disclosure, I'm not paid by anybody for anything. I'm speaking purely as a very happy customer of Biomedix because we use their product, and also a pleasure to meet Dr. King and Dr. Krause. And one thing we have in common with podiatrists is that we both love feet. I'm the endovascular specialist. I have to fix the underlying plumbing. You have to fix the structural issues, whether it's bone, tissue, wounds, and we have to collaborate together. And for healing to happen, blood flow must exist. And this kind of incision is not the gold standard anymore. And so we obviously focus on endovascular techniques. One of the biggest problems that we face today, that people don't realize, is atherosclerosis is the underlying problem. For whatever reason, whatever the research may show, but lifestyle factors, genetic factors, as we accumulate lipids in these arteries, you get the inflammation, you get plaque, and then you start developing problems in different organ systems. The commonest you hear of are stroke or heart attack. The PAD is no different. Claudication in the leg is no different from having angina. So if a patient walked into your office and said, I was walking here, I had angina, you probably send him to the ER. Or if he told you I had a TIA, you send him to the ER. Unfortunately, in PAD, people don't say, oh, you got pain, oh, walk some more. The problem with that is they have the same mortality and morbidity, and they will die from a heart attack or from a stroke. So it's not a minor disease or something to look over. And obviously, we don't want this leading to limb loss in the long run. So PAD, the problem with PAD is obviously a silent disease, and majority of it is atypical. We'll talk about that a little more. So I'll show you a little bit of how we partner with podiatrists. We work with tens of, if not hundreds of podiatrists. We have Biomedix in about 30 of them, and we've connected with them. So here's a patient, and this patient we followed over 5 years so far now. He was 65 years old, on dialysis, diabetic. He had some wounds, and the podiatrist, one of who we work very closely with, sent him to us. He had been advised amputation by several folks before. He's gone to a vascular surgeon, and he said, well, I don't think I can do much. Most of it is infrapopliteal disease, and they recommended amputation. So this was in January 13. He was worsening by March. You can see the wounds much bigger. And he was sent to me. We looked at him. We realized that he had occlusive disease. That's his SFA here that we've opened up, and you can see the flow going through. Infrapopliteal, you can see the anterior tibial artery has occlusive disease. You can't see the peroneal at all, and the posterior tibial. And the posterior tibial, the posterior angiosome, is what supplies blood flow to the heel where you saw the wound. This is after we've opened it. So now as we walk away through it, if you look at his journey, this is the first time we saw him, 2013 January. This is in March. It's getting worse. By December, between the podiatrist and us, most of this had already healed. We followed him over several years. He's had one or two kind of what I call touch-up procedures. He was getting a stenosis. We do surveillance where we monitored them every 3 months. He's been with that podiatrist ever since, and this was the last time in March. Now, this gentleman otherwise would have had an amputation. The cost of amputation is high. I speak a lot on this, and I always ask people, imagine you don't have your foot. How does that feel? And it has a massive impact on one's psyche, the entire way they lead their lives. There actually is a spiral down from there. And in the past, looking at disease like this, it was just that you can't do anything. Now it's routine for us to be down in the foot, to kind of be able to get into the dorsalis pedis, the posterior tibulari. We puncture the dorsalis pedal access, dorsalis pedis, posterior tibulari, peroneal artery, and go up and open it. Most of this, if not all of this, we can do outpatient in our outpatient lab and send them home the same day. Technology has come a long way. Plus, at the same token, the techniques that we've developed have also come very well. So together, what we are doing is really preventing amputations, keeping limbs healthy, and helping people live better lives and longer lives. Now, we've been doing this a long time. I've been doing this 30 plus years. And manually, the transfer of information, etc., almost always was the biggest challenge. And if you got a call today, how could you get this scheduled and done and turned all of this around? And there are so many people involved in the patient's care. First, the patient.
Romy, I think we lost you. You froze.
Well, Dr. Kraus, I texted Dr. Chopra, and I'll wait to hear back from him. I'm not sure if he's having internet issues. Yeah, what I can tell you is we've been working, this is Chris Trygstad, a marketing director at Biomedix. We've been working with Dr. Chopra for well over 5 years. He is connected to a number of podiatrists around the Chicagoland area and enjoys, collaborating with podiatrists in his catchment area. And what happens is those vascular tests are done at the point of care. And he likes to see that. And he is able to not only deliver a diagnosis, but also care plans along with that. So that could result in a referral to his office or some other intervention. And Dr. Chopra's back.
I'm back. I'm not sure why the system kicked me out, so my apologies. So we were talking about.
I don't know what's happening.
Yeah, it looks like he froze up again. I'm not really sure what's going on. Is there a dial-in number that might work best?
I'm not sure. Let me.
Well, tell you what. I mean, yeah, this is Chris again. Looks like he's back in. Okay.
Yep. It's got to be in Chicago.
Romi is in the building.
I thought he was back.
I thought so too. Yeah, but I guess what Dr. Chopra really prides himself on is collaborating with those nearby physicians. So it's not a podiatrist performs a vascular test on a patient. That patient comes in for an intervention, and then you never see that patient again. Dr. Chopra is really committed to being transparent in terms of telling that physician he's collaborating with what actually happened to that patient, the treatment that was delivered to that patient, and more importantly, sends that patient back to that podiatrist. He really understands the importance of, comprehensive foot care and how that can impact a diabetic, ensuring that, those feet are being treated and evaluated on a regular basis.
I think it's really important. We've seen this great collaboration between podiatry and Society for Vascular Surgery and people like Romi, which has just been so critical. I think you can see that with the numbers of podiatric entities that are being absorbed or supported by vascular groups today. There we go. Romi's back in the building.
Hey, Romi. We just changed to the next slide, and we were just filling in for you. So
thank you.
I think Chris covered a lot of things on here, but I'm going to put it back here in case you wanted to make any comments.
Thank you. All right. So what we've been able to do is use PadNet screening as a link between our MIMIT Health digital platform and the podiatrist. And we really wanted to have an acceleration of how we can take care of people. Just as, you go somewhere, you look at something, you say, I want this, you look at Amazon, you click the thing, and next you know that thing's on your way. So what's behind that all this that's making the velocity of conducting a transaction faster? And we knew that we needed the digital transformation there. So PadNet, as you screen the patient, and we encourage you to screen the patient, we'll talk about which patient should be screened. When you screen the patient, that sends the information to us. We look at it. If there's any suspected PAD, we have a referral system in place. We take care of the problem, send them back to you. And remember that PAD is not a isolated kind of infection like you get the influenza or something like that. It's a chronic disease that's linked to diabetes. You take care of diabetic foots. It's linked to coronary artery disease, et cetera, hypercholesterolemia, et cetera. So we obviously then follow these patients for life and make sure that they're constantly coming back to you. And this effective partnership, which was enabled by PadNet, started becoming the bridge. We are right now connected with over 35 podiatrists this way. In fact, we've even had arrangements where we share office space with some podiatrists. And to give you an idea, a patient called on Friday. So Friday was this podiatrist clinic. He called me, he said, listen, I have a patient. I said, text me the name, which is part of our system. And we call the patient, this is on the Friday. We see him that same afternoon, actually has the procedure on Monday as fast. And we've set it up where the information gets back to the podiatrist very quickly so he sees what's going on. So this is kind of how we've set that up. You have the podiatrist's office, you do the PadNet study there, you screen the patient. It's done in Biomedix. Biomedix, the information comes over to us. Obviously, you bill for the study. It's ethical, it's legal, it's logical. The cost is extremely low. It adds revenue to you, but you're providing a great service to the patient. This information, literally, we get notification. There's a study, usually within 24 hours, we'll have studied it. If it's something very serious or high or severe disease, we'll call the podiatrist. If it's mild to moderate, then we set up an appointment to get them. We have our own digital platform. I'll give you a little flavor of it and why we use this whole concept of, what's the right word, Amazonification, as we were talking about. So now how do you know that the patient has PAD? Well, one is obviously you could examine the patient, etc., but most patients don't even talk about pain in that, especially if they're diabetic. So most PAD patients are asymptomatic, and therefore most people don't even test them. So one of the things to look at is the risk factors and then say, listen, if somebody's more than diabetic for 10 years, even if he doesn't have a wound, the patient's at risk above age 50 with history of smoking or just those who are above 60. Any wound, or if they tell you that they have pain, it does not need to be typical claudication. If they have rest pain at night, usually the way we describe rest pain is, in the day, the pressure is up, they're walking around, they're stimulating the sympathetic responses up. But when they go to sleep, blood pressure goes down, they start to rest. If there is a stenosis or some occlusions, the blood pressure as it goes down will cause the flow to the foot to decrease beyond a certain level. And then they get pain. It wakes them up. They dangle their feet over the bed. They'll walk around. They start feeling a little better. That's kind of a typical scenario for rest pain. Now, any patients who are at risk prior to any foot, ankle surgical procedure, good idea to have them assessed. And the easiest thing is in your office, do the PadNet study, and then you send them to us. Some people have asked us, why don't I just send them to you anyway? But you may not need to send everybody. Just look at those who are at risk. It's better for the patient. It's easier for the patient. It's better for everybody. It's win-win all around. So what we are trying to avoid is critical limb ischemia and try to avoid getting where they land up with an amputation, because limb loss is a very expensive proposition. Most patients are dead within 2 to 3 years once they've had an amputation, and you really don't want. So for us, one of the things is we have taken all of this outpatient. So to get the patient in and out, it's much easier. They're not admitted to hospitals now with COVID. There's all this risk around being in a hospital, of getting COVID. And most of these patients are, one, elderly. Two, they may have underlying conditions which put them at high risk if they get COVID, diabetes, hypertension, renal failure, etc. And you can see this patient here. You can see how the tibioperoneal trunk is diseased, posterior tubules occluded, peroneal arteries occluded, and the anterior tibial arteries occluded. And here you can see after we've opened this up. And this is all outpatient in our office-based lab. And the cost to the patient, to the system in general, and these patients are back to you for follow-up and whatever care they are getting from you. So one of the things we've been able to do with this, make it very convenient, but the most important thing is that the podiatrist stays connected in all of this. You'll get a fax directly from our system. You can log in and see pictures, etc. But the point is, how do we get you to stay within the care plan for this patient? Now, one of the things we've done is that there is no patient, just like there's no flight plane ever takes off without one, a flight plan or control tower knowing. So we do a lot of care coordination. We have every patient gets a care plan and every patient gets a care coordinator. So we do that. So a little bit about MIMIT Health. It was founded back in 2003. I was just fed up of being in large academic institutions. I was chair of a large department, tenured associate professor, got tired of the politics, started MIMIT really as an interventional radiology group, but it started growing from there. In the Chicagoland area, we have about 7 outpatient clinics now. We're in almost actually 40 nursing homes now, multiple hospitals, etc. Our focus has always been minimally invasive, but really, how do we make sure that the patient gets the best care? And I'll talk a little bit more about that. But one of the key things that happens is, how do you get the right information to the right people at the right time to make the right decision for the right reasons? And that becomes the challenge. So people ask us, what do you do at MIMIT Healthcare and why are you so different from everybody else? I just had, and I did the procedure today, is the father of the prime minister of a Eastern European country. He could have gone to, I don't know how many places, and he's incredibly wealthy. And he's flown down here now. This was the 3rd time, and I'm taking care of him here in our office-based lab. Why? Because it's patient-centered. We are connected with him. He's in another country, but with telehealth are doing all the stuff. We have an entire team of people collaborating, his physicians, which are practically 2 of them are in other parts of the world. And that's what we call the Amazonification paradigm, where things are done better, faster, and cheaper. I mean, what we've done in an outpatient setting, the cost in the hospital is 3 to 4 times more. He could have gotten COVID and all the other bureaucracy and everything else that goes into it. So this is kind of our paradigm, just to talk a little bit about, patient-centered. And if you look at the Amazons of the world or the Costcos of the world, they know everything about you. We call it kind of customer 360. We call it patient 360. So we make sure that we have a 360-degree view of the patient, not just, oh, they have an ulcer and I got to do an angiogram and I take some pictures and send them home. And for that, we needed a platform. So we actually use Salesforce, has a product called Health Cloud and other things that we use as a platform It's kind of a little beyond this topic, but we do all kinds of analytics, et cetera, to kind of make sure that we are coordinating care and providing all of this. This is not something you need to do. This is where, with PadNet, what we've been able to do with the podiatrist is get connected, where we can now get the correct patient identified that has a problem, send the patient back when you need it, but our platforms will get all the information to you as and when you need it. So this, we talked about the Biomedix part of it, but we've taken all other technologies and everything is integrated on this platform. And that's the Amazons of the world do this all the time. So why follow Amazon's principles, right? So one of the biggest companies in the world, it's been a thought leader and in the forefront of technology all this while. And despite the position in the market, and I've studied Amazon very well, there's a new book called The Amazon Effect, written by Ram Charan. He had written a book called Execution, for those of you who may like leadership and business kind of topics. And, you know, execution is key. A brilliant strategy, poorly executed, will always be taken over by even an average strategy that is very well executed. And that's what we try to do. And when you study them, you know, they started as an online bookstore, just a little thing, and they were growing, but now they've become a mammoth, and their innovation is tremendous. This is something we believe in. We say that every system, no matter whether you're playing sports, it's business, it needs 6 right things: the right structure, the right processes. So we are very, very process driven. And one of the things, and that's what people call workflow, et cetera, with this system of connecting with the podiatrist, once we got the workflow working very well with PadNet, it became so easy for the patients to get identified. And you can see we're working with about 40 podiatrists now and different offices, and we're connecting and communicating with them. Obviously, the right people to do it. You got to make the right decisions with the right information, and definitely for the right rewards. This is another thing that I talk about, and the first thing you'll notice, whether you shop at Amazon, Costco, some of these big companies that you work with who are recognized for their excellence, they will give you an excellent product or service. If for any reason you're not happy, they'll give you excellent customer satisfaction. Those two are given by excellent employees because the employees bring in the other two things. Fourth is they're fiscally responsible. What does that mean? They make a profit, but they will make sure that you get brilliant value. Amazon will tell you this is what you're saving. You can find it cheaper from somewhere else if you wanted to, but here's the advantages of being a Prime member, etc. And that fiscal responsibility of really adding value and having a win-win situation is really what brings about loyalty within your patients and customers. So we work very hard on making sure patients, we can check their insurance right up front. We tell them what they may owe us, copay, et cetera, et cetera. The fifth pillar is continuous innovation and improvements. These companies are constantly innovating, constantly improving. And the sixth is they will sustain these 5. This is what we've put into practice. It's not easy. We work, you have to work hard at this every day, but that's what it takes. And, they call it the S curve when you look at innovation. And some people describe this like you're going around a spiral up. As you make one turn, and I tell my team this, as an organization grows, as our practice is growing and we get maturity, so you're infant, you become an adolescent and then an adult, at some point things plateau, certain people fall off, some people decide not to get innovative and then they will complain about the old days, etc. But once you start to get this, and this is happening in healthcare, it may not be a new fancy product, but really a solution around the patient to solve their problems. And today when you look at it, Amazon really he's one of the richest guys in the world now and be a trillionaire. But what we have done is taken Amazon principles, Uber principles, Airbnb principles, and then applied it. So for example, instead of every time we open a clinic, we just don't go and build a building. We've collaborated with podiatrists. We legally and ethically share office space with them, whether that's OR space, etc., and are able to have a win-win deal, but always centered around the patient. So for us, we are incredibly obsessed with patients. We see them at home, we see them in SNFs, we see them in LTACs, we see them in a hospital. If they move, we follow them. And if you send me the patient, you will always hear back from us. We make sure we are connected with you, with them, and work our way. And that's exactly what patient obsession means. We'll take a call from them anytime. We have contact centers and everything else built around it. I could go on forever, but we'll cover more in the question and answer session. Dr. Krause, Dr. King, I don't know if Chris wanted to talk more about PadNet or anything else there.
So thanks, Dr. Chopra. Yeah, this is Chris Trygstad with Biomedix. Just a quick few thoughts on PadNet, in case you haven't heard of PadNet before. PadNet is a device really designed to be used in the front lines of care to perform non-invasive physiologic vascular screening and testing. This is a test that does not require more of the doctor's time. It can be performed by a medical assistant, and a test can be performed in about 10 minutes. In terms of reimbursement, obviously that changes by the market and by the plan and number of factors that come into place. But podiatrists typically get paid about $120 per test. I think one thing we hear from podiatrists using PadNet is that it actually enriches the customer experience. So you're elevating your practice beyond providing routine foot care, and you're actually, to Dr. Chopra's point, holistically evaluating and potentially treating that patient. By doing so, you're able to improve those patient outcomes. And then if you are prescribing diabetic footwear, the supporting documentation provided by a PadNet test is a really easy way to cover some of those compliance requirements, specifically Section 2F for diabetic footwear. And I think most importantly, it enables that community-based collaborative care. So you as a podiatrist, seeing these diabetic patients, every 60 to 90 days, elevating your practice through the identification of this chronic condition that's deadly and expensive to treat. And if you're able to detect that disease early, you can bend the healthcare cost curve, you can improve patient outcomes, and without any additional time in the office or additional patients, you can have a positive impact on your bottom line. I'm just going to pause here. Dr. Krause and Doc, can you hear me?
I can.
Yes.
Okay, sounds good. Okay. So I think Dr. Chopra needs to hop back on, or
I'm right back on. Good.
You're back on. Okay, sounds good. Okay. Dr. Chopra, do you want to talk a little bit about PAD and heart disease?
Yes, absolutely. I just wanted to make sure that we had covered that part on PadNet as well. So
Great.
Some key points to bring up that, as I mentioned, if a patient walks into your office and he says, I had a TIA or I had chest pain as I was walking in, you'd send me to the ER right away. Similarly, PAD, which is the underlying atherosclerosis, it's the plumbing. If it rusts, it's going to affect all the rooms in the house. The same way, 75% of those patients who have PAD are going to have coronary artery disease. And many of those with PAD and heart disease don't receive treatment until the heart disease is very, very evident. That's why it's important that because you see feet all the time, especially when they are relatively asymptomatic, is to check for PAD. And a patient with PAD who's not yet identified or otherwise has a 6 times higher chance of dying from a cerebrovascular or a cardiovascular incident, which means they'll either die of a stroke or they'll die from a heart attack. And so obviously we treat the underlying medical condition as well, but it's important that you identify that because they may never come to somebody like me. And when you look at the economic burden, everybody talks about cost of healthcare. We're almost a $4 trillion healthcare economy out of a $22 trillion economy of the US. We spend more on PAD than on diabetes, CAD, and cancer. It is really prevalent. We're talking about roughly $319 billion in the US compared to $176, $148, $88 with diabetes, CAD, and cancer. And in general, especially with Medicare, because they track the cost, and most of these patients are old, most of them have Medicare, the PAD, especially when it's cost per patient, is way higher than anybody who does not have PAD. So we know it's a very significant problem. It's better to catch it early and work away. Amputation, once it happens, and it's obviously the underlying PAD will take a small, slow healing diabetic foot ulcer, get infected, it gets beyond to gangrene, now they get an amputation. Once you have somebody who has something like that, a low extremity amputation, there is a 200-fold increase that they will go to another one. And the mortality for these is close to 50% at 1 year and 71% at 3 years. That means half your patients, once they've had an amputation, are going to be dead in a year. And about 3/4 of them will be dead in 3 years. So it's not a minor problem, so to speak. Now, when you look at amputations, about 2 million in the US are living with limb loss, and half of them are because of vascular disease. They are close to 185,000 annual amputations. You can see this is the same number that you have patients who've died from COVID right now, how much attention it gets, but most people don't realize how many amputations occur a year. And most of these patients have not even had a vascular exam, and that's one of the most important things. So spend a lot of time educating folks that the screening will save a lot of cost downstream. And the 2-year cost of a low extremity angiogram is over close to 100,000, 91,000, and lifetime, $500,000. So an amputation is not a cheap thing to have. On top of that, it's not something anybody wants, and therefore it's a problem. But once we start coordinating healthcare, as we talked about, that's what I call the Amazonification and the digitization. You take care of them earlier, fewer emergency visits, fewer hospitalizations, fewer hospital visits, decreases the cost, the quality of life gets up better, and it really helps. We've already talked about PadNet, but for your practice, first thing is it serves the patient tremendously. The second thing is you'll get better care, better outcomes, because once their wounds have healed, etc., they're going to come to you forever. They're very grateful when you've caught it early, especially if they didn't know they had that. And for a podiatry practice, it's really incremental revenue. The podiatrist doesn't have to do much. The office staff does the screening. It shows up to in our office and we look at it. I'll let Chris talk about this particular thing since I don't know too much about this promotion.
Can you hear me?
Yes, I can.
Great. Well, I'm going to jump on, Romi. I'm going to talk a little bit about this. Sure. So personally, I have actually been using Biomedix for a really long time. I don't want to say I was one of the first, but I was in the early stages of using the PadNet machine and have gone through multiple iterations. And I remember when I started implementing it in my practice, I went to my vascular surgeons in my community. I was worried about losing my referral stream and asked them if they would have a problem with this. And it turns out that it actually made me appear better in their eyes because of the fact that I was able to screen and identify patients that needed help. But we've had a great relationship, myself and Biomedix, as well as Taylor and Biomedix. And Biomedix wanted to do something unique today. They wanted to kind of, offer something as a thank you for joining the seminar if you decide to purchase during PAD month. And they are going to be giving away a UV sanitizer sterilizer. It kills 99% of bacteria and viruses. You press the button once for a short 90-second cycle or double click for a 5-minute deep clean. Can be used in keys and other items. And of course, who doesn't need a wireless charging pad on top of it? Anyway, this is just something that Biomedix wants to do to show its appreciation to Taylor members and for increasing better outcomes for patients by utilizing Biomedix technology. I'm going to close on that note. I believe that was the last slide, and I'm going to turn it over to questions. And Mike, why don't you start the show off?
Okay, super. So typically, Dr. Chopra, how long does it take to read the exam, and how long does it take for you to get the results back to the DPM who did the testing?
So as soon as the test is submitted by the podiatrist's office, we get notification in our system, and I get an email. And as minute I see the email, for me, it's a click on I do it on my note or handheld. You can do it on an iPad or whatever. I click on it, see it. So usually within 24 hours, we've got the result down there.
That's awesome. So I've got this guy has a multi-part question, Romi. It's what is contained in the interpretation? You include your impressions of the diagnostic data as well as a care plan, which may include a consult at your office. Is it appropriate for the podiatrist to do vascular screenings? And why not just send the patients directly to you?
Sure. So the first thing is, you see the patient, and sometimes you can screen them right there, number one, because if you keep sending them to me, there may be a delay, there may be a problem. The second thing, and sometimes you may not even know, so you don't know who to send to me, so it's better to screen. That's number one. It is absolutely appropriate for you to screen. It's completely ethical. It's within the guidelines. As you're looking at a foot, you examine and you do that. And once you've done the test, basically what we are looking at is the waveforms that you see within the thigh, in the calf, in the toe pressures, and then after that we do the ratios. So you look at the ABI. So I look at the waveform to see whether it's triphasic, biphasic, monophasic. I look at the pressure, and I look at the gradients and the drop. Now, if there is, and then based on that, I can say, is it mild, is it moderate, or is it severe? If it is suspected, if it's mild and there's PAD, I would say, listen, it seems like there's mild PAD. You should check this out compared to completely normal. Why? Because you may want to identify hypercholesterolemia and underlying factors, put them on aspirin, Plavix, whatever they may need, and they now know they have this. So as they age, as part of the well-being, they'll keep an eye on this. So that's number one. So if it's any more severe, in our note itself, we will say, I suspect disease at this level. A consult is recommended. Now, we also read studies for some folks who are not very close to us, and they may choose to send it to somebody else. That's fine. For us, the interpretation fee is very modest, but that's okay. The technical fee is received by the podiatrist and the office that does the work. Again, that's ethical, legal, and fine. But we provided the patient a service. So that's kind of how we do it. I hope I answered all your different parts of the question.
You did, Romi, and I'm actually going to ask you a follow-up on that you made me think about for myself. Couple of questions. Obviously, if the patient needs a consultation and you have then provided some type of endovascular work, moving forward, I guess, how often would you retest the patient to see if the work that has been done remains patent, or if there's an issue? And then when that happens, is it more appropriate for you as the endovascular specialist to be doing these follow-ups, or is it still okay for the podiatrist to be doing these periodic follow-ups?
So there are two parts to this. The first is, obviously, if there's a wound and whatever else you're doing as a podiatrist on the foot, you should do. We, by kind of policy or basic principle, we'll see them every 3 months, number one. And we are making sure that vessels are patent. If let's say I did an intervention today, there's an SFA occlusion. We know that there are certain patency rates on certain types of diseases. Those, we don't expect you to follow them and know enough about them. So it's my responsibility and the endovascular specialist to follow that and take care of that patient. So we will do that usually every 3 months. We do the ultrasound in the office. But let's assume, as they're doing great, it's been 3-4 visits, then we increase the interval. So let's say we'll increase the interval to 6 months, and then sometimes I have patients I've been following for 18 years. But when I see them in that 1 year in between, let's say they come to you for something and you suspect something, you should do that PADNet test or send them back. But what you don't want to be doing is every time they show up, do the PADNet, because the PADNet is really a screening tool and not a completely diagnostic tool like ultrasound and Doppler. I hope that helps you.
So a follow-up to that, since you used that term, is Medicare approving screening for PAD?
Yes. This is reimbursed by Medicare. So this is reimbursed by Medicare. Every one of the podiatry offices that and primary care offices we worked in have, they get reimbursed for this, and you get the technical component for that because you're doing the work, you're leasing it. So obviously, if you set up this program right, so for example, one podiatrist that we set this up for, they reviewed their medical records. They looked at all the diagnoses that, let's say, were hypertension, cholesterolemia, et cetera, that were in their diagnosis. Those patients were identified. Then you went through the screening tool to see who were candidates for screening. And when they came in, they got screened. And now some of these patients, especially as they get older, and we're all getting older, once you get above 60, you may not know you have PAD, but that means you have underlying atherosclerosis, which means you could have a stroke, you could have a heart attack. So you want to catch that. So for the practice, it can be quite a good thing to go through that process, set up that process right. Now, in your office, when the patient shows up, you're not doing the test. Up front, there's a form, they fill it. If they meet the criteria, your office staff will do the PADNet study. That gets submitted to us electronically, and then you get a result back.
Yeah, and this is Chris Trygstad. I just want to chime in here. Just wanted to kind of clarify, screening versus testing. At Biomedix, we typically advise people interested in reimbursement. In order to get reimbursement, you really should be testing patients that present with primary indications. Although the prevalence shows that many patients present with atypical symptoms, it's really a practice of the doctor of querying those patients through questionnaires and asking questions and ensuring that you're getting straightforward answers is really kind of key to that. So, and
Thanks,
I'll jump
Chris.
out here. Yep, you're welcome.
So, Romi, in your experience, does early detection have a positive impact? And how?
Absolutely.
Okay.
Sorry. Continue your question.
Oh no! I was running too long. Mike, you want to take the next one?
Sure. So I think you brought up an interesting point, Romi, when you were talking about evaluating the patients based upon numbers of factors. What about that patient who comes in with palpable pedal pulses, but yet you still have a suspicion of PAD?
Yes. So one of the things, if you have palpable pulses and you may have suspicion, if it depends on which angiosome. So if, let's say, the dorsalis pedis is palpable, but he's got some problem, you can feel the posterior tibial pulse, and you start to see some problems around his heel, it may mean that his posterior tibial artery is got some occlusive disease, and the posterior angiosome is not getting enough blood, so it's worthy of a test. But if all pedal pulses are palpable, and the foot's warm, everything is good, then it's extremely unlikely. But if they're smokers, they're over 60, they have a diabetic, and you may think that the toe pressure is because they can get microvascular disease. So you have to put in a little bit of clinical judgment over there. Otherwise, it looks like you're just testing everybody. But if there's some suspicion, so we see a lot of patients who have some problem on the toe, they have a pulse, but they are diabetics and have microvascular disease. Then you see a drop in the toe pressure. So it's better to check and make sure they are normal versus not check, do some procedure, and then find out they're getting gangrene, and now you got a problem.
Right.
You mean gangrene's a problem? So I guess, you talked so much earlier about patient satisfaction and
yes.
and patient-centric care, and how you collaborated with with the podiatric community. Is there any other ways that you've collaborated with nearby physicians, even other than podiatric physicians? Is this something that can help the podiatric physicians grow their practice as well?
Oh, absolutely. So one of the things that we found now is, obviously, we'll get patients for vascular problems. And if they come for a problem, we're always being vascular guys, we'll check their feet too. And we found ourselves referring a lot of patients who have not been to a podiatrist to the podiatric community. So we've got a database of, hundreds of podiatrists now that we work with, and depends on where they are, we will say, I think you should really not trim your own nails, or you've got the problem here, you need to see the podiatrist. And interestingly, a lot of patients come in and they don't realize they have, for example, plantar fasciitis. So instead of me trying to treat this, they need orthotics, they need help, we will refer them to podiatrists. And the other thing that we've also done is, in terms of wound care, we'll send them to podiatrists if they show up with us who, they've not had proper wound care or something like that. So it's a mutually beneficial thing.
I think that's an interesting case you brought up there too, Romi, is that I'm trying to think of the numbers of times I had a limb salvage practice outside of Boston, and the numbers of times I saw people come in who thought they had plantar fasciitis, but they were actually having arch claudication.
Exactly. Yeah.
And, they otherwise they were asymptomatic as far as, their appearance, but they were getting arch claudication. So they were having one of those, lower leg angiosome blockages, which was interesting.
Yeah. And, the techniques for us literally routinely, I'll be down in the foot in the plantar arch and doing a pedal stick, so today I did one radial intervention. So from the radial artery, we're going all the way down into the foot. Occasionally we've done it where we've gone from the radial down halfway down the anterior tibial, and I can't get through the occlusion. I punctured the dorsalis pedis, connect all the way up, and I got to wire out the radial artery and wire out the dorsalis pedis artery. And
so do you do retrograde entries from distal to proximal?
All the time. Yeah. All the time. And all of this is in the outpatient setting and in the OBL, the office-based lab.
It's amazing when you think about, I've been in practice now 30 years. And the reality,
started when he was 12.
The reality is the standard of care was, BK amputations when we came out, and I've seen things change, but, not only did Mike mention about the patients with plantar fasciitis, where I practiced in Chattanooga, we had a lot of delivery. We have U.S. Express is centered there, a Bluebird Bus Company, and Amazon is there. There's just so many different Little Debbie cakes. There's a million companies with truck companies there. And I'll tell you, even to the point of, I used to have, I would say truck drivers, 35 to 55, who sat in the truck 12, 15 hours a day and smoked cigarettes. And they were getting calf pain. And the reality is they thought they were just having cramps in their calf from sitting. And the reality is that they also were PAD sufferers. So, finding these patients early and having the abilities and the tools to be able to test them, that I think that really helped me in my community, because my MD and DO colleagues realized that I was looking for and finding pathology in patients who thought they were just suffering from a muscle cramp.
Yes,
and it's just so different.
And the patients get very, very loyal, and they'll never forget it. We've got many podiatrists who will find something and send it to us, and they are so grateful to the podiatrist, saying, if you hadn't found it, we wouldn't have taken care of this. And especially with the diabetics, that when they're chugging along, they fall off the cliff very fast. And so the faster you catch those, because with the neuropathy, they don't feel much. And those guys are younger too. And those are the kind of guys who are driving trucks and doing stuff. They're either smoking, they're all the bad diets, and the diabetes is not under control. And next, they have an amputation. So I think that's good work that you do there.
Well, I will tell you that what I found, my practice, like Mike's, was critical limb ischemia probably for my last 20 years. And I mentioned to you my colleague in Chattanooga who I worked with, and his brother actually became a podiatrist because he told him, don't do what I do, do what Krause does. He has a better life. So actually his younger brother is a podiatrist. But the reality is that what I have found, when I graduated from podiatry school, and I hope I don't offend anybody on the phone, much like many of our new young graduates that come out, we have a great surgical background and a great surgical training, and everybody wants to be a reconstructive foot and ankle surgeon. But I will tell you that the patients that really were the most grateful to me were the ones whose limbs and lives that I saved. The reality is, when we were younger, we said, why do you want to get involved with limb salvage? You're going to be married to those patients for years. Well, the reality is, if I did reconstructive rear foot and ankle surgery, I was still married to those patients, and they were not as gratified or as grateful for the work that we provided. So, it really has been not just. It's just because it was a personally gratifying type of practice to have. It was hard, and there was a lot of work, but it was very gratifying.
That's very, very true. Yes.
Anyway, I think that we've done well, and Mike and I try to start on time and end on time. We did have a few technical difficulties, but I think we did very, very well. Dr. Romi, do you have any closing comments that you'd like to make before I kind of close out everything from Taylor Medical?
I would just say, if you're a podiatrist and have still not partnered with an endovascular person, please do that, because you'll really serve your patients and find the tools, whatever that may be for you, that will stay centered on the patient. Your life gets better, and it's amazing. We've grown over 40% every year for the last 5 years.
Well, that's awesome and exciting. Mike, do you have any comments? I know you're part of a large group and growing. What do you, any of your thoughts on the vascular podiatry compromise?
I think Rami's point about the office-based laboratories, also known as OBLs, when you hear that term, is the wave of the future. And working for a value-based healthcare company now, it's all the rage, because the facility fees of major institutions are absolutely devastating the wound care and the PAD industry. So early recognition with testing like what Biomedix offers, and quick referrals to interventionalists like Dr. Chopra just make all the difference. And it's interesting, going back really quickly to the question we talked about screening, is that for all the grief that all of us get about screening things, all of the major payers do know that those are the things that recognize disease early and fix disease early. So I think we need to be in that cutting edge. I know you guys are at EHI as well.
Yep, I agree. Well, I want to thank everybody for joining us. This has been great. I get to I haven't seen physically one of my very, very dear friends in a very long time, but I get to see him at least every other week on Tuesday. And it's been fun moderating these. I'm actually really excited. Our next Taylor Tuesday is October 6th. And we're going to talk about shockwave therapy to treat overuse in sports injuries. I know John Connors very well. John was actually one of my attendings when I was a resident. He has been doing working for the Olympic team in the track and field area, and I believe his associate is Dr. Kathleen Trotta, and they're going to be coming on and talking about shockwave therapy. Again, I think it's about patient-centric care and offering the right services to patients. I want to thank you all very, very much for joining us tonight. I want to thank Biomedix for sponsoring and bringing this to us. I want to remind everybody about Taylor Medical, and I want to remind you about utilizing Taylor to help in your practice during COVID. Hopefully you guys have streamlined your practice and looked at your protocols and figured out places you can save money, and also thought about things that you can add to the practice. That's why this talk was so appropriate. This is something that you can add to your practice to help you get better outcomes for your patients and also improve the bottom line. So with that, I'm going to bid everybody adieu. Mikey, I'll speak to you later on in the week. Dr. Romi, if you're still on, thank you very much. Chris, thank you from Biomedix, and I hope everybody has a great evening. Good night, everybody.
Thanks, everybody. Appreciate it.
Thank you, everybody.
Bye-bye.